All right, hello everyone, welcome back. I'm your host Aman, CEO of Sandprem, and today we have a new special guest, Dominik Burziwoda. Is that right?
That's great, yes.
And Dominik is the CEO of an exciting company called Perfood. And Perfood provides, in my own words, AI driven nutrition therapy. So here's what that means. The idea is that if you continuously monitor your glucose levels and inflammation spikes and other data points from your body, then a machine learning system could accurately use that data to predict things like when you're going to have a migraine, right? How your your gut biome is reacting and other things. And based on that, it can guide you on how to change your diet or nutrition in a way that keeps you healthy. So instead of prescribing drugs directly, the system basically believes in changing the food on your plate as the main tool for improving your healthcare plan, your personalized healthcare plan, and it uses AI as kind of on the diagnosis stage to figure out what's going on and how it needs to intervene, right? And I'm going to let Dominique expand and clarify things in a minute. But thanks for being here, man. What's up?
Thanks, Aman. Thanks for having me. It's great to be here.
So, was my quick overview anywhere close to how it works, or do you want to correct us? Do you want to expand on that a little bit?
Yeah, no, I can tell you a little bit more about what we are doing at Perfood. We are, and I apologize for the difficult name you have to cope with. I know it's a tough one, even for most people over here in Germany, and among my friends and coworkers. It's really difficult to pronounce that name. So I'm happy we go by the first name, Dominik. Actually, it's a reason. The difficult last name, I guess, is the reason why I'm by first name, which is untypical in Germany with most people. So it's an opportunity to get more comfortable quicker, I guess. Yeah, so what Perfood is doing actually is we are developing digital therapeutics, and this is a big market where many people are currently looking at, because 80% of all diseases are related to lifestyle, right? And so to prevent the progression of these diseases, or to even reverse them, we obviously have to adjust our lifestyles. And digital therapeutics is the solution to that, because they help patients to take personalized, specific actions to reverse a certain disease. And it's actually a variety of diseases. And Perfood is focused on specific diseases, namely those that are related to the blood glucose metabolism. And usually when people think about the blood glucose metabolism, we think about diseases like diabetes, right? But it turns out that there are actually many more diseases linked to the glucose metabolism. And that is because if you have strong variation in blood glucose, which generally happens after you're eating something, but also other factors influence your glycemic responses, such as sleep, sports, stress, for instance. And if you have strong variation, you increase systemic inflammation in your body. And since glucose is the most important source of energy, when I say glucose, I mean carbohydrates that have been transferred into glucose by our metabolic system, we are also very sensitive to variations in the energy that we have, because we need energy all the day, right? We are thinking, we are talking here now, we are concentrating. And back in the days when we were out in nature, perhaps we needed glucose as an availability to be hunting for fight or flight reactions when we got into trouble. So it's a very important energy source. And that is why our body reacts sensitively to strong variations in glucose. And what we observe is that it is a great biomarker. And if you stabilize blood glucose, then you can treat diseases very effectively. And we use personalized low glycemic diet, in which we determine what food you should eat, but also how you should behave to keep your blood glucose levels stable, to as an active ingredient to treat diseases. So you can imagine that there are digital therapeutics that tell you, hey, try to eat healthy, right? And it's really difficult.
Yep.
We all have problems. And meanwhile, we know that actually our bodies react completely in a personalized way to food and to any actions, actually. So it's important to personalize. And this is also where AI comes into play.
Yep.
And you better your calculation, your analysis is, the better your recommendations are and the more effective the digital therapy will be. And also, the better the adherence of patients will be. And this is what we're essentially doing. And we are developing an entire pipeline. Our first product is for migraines, but we have other products currently under development. We are strongly looking at type 2 diabetes. We're looking at oncology, at neurodegenerative diseases, at autoimmune diseases. And we have a couple of research projects with universities ongoing where we are really building up that pipeline.
I see. So when you mentioned that you can not only diagnose a lot of issues in the body based on just the glucose levels, right?
Mm-hmm.
And the inflammation marker. So does your system actually track inflammation markers, or is that something you predict instead based on the glucose levels?
Yeah, that's a good question. So the issue with most inflammatory markers is that they are really difficult to track on a continuous basis. So usually you determine inflammatory markers with blood samples, and sometimes even you have to take them at the very region in your body. For instance, if you have an inflammation in your knee, then you would actually take a sample from your knee. So that's painful, obviously. It's like surgery almost. Yeah. So what you can do is you can find surrogate parameters, proxies, essentially, for these inflammatory markers. And that is a great benefit of the glucose metabolism or of continuous glucose measuring, because it's a very good proxy for hormonal processes and for inflammation in our body, right? So, for instance, in diabetes is a state oftentimes accompanied by obesity, and that is a state of chronic inflammation, right? So we know when people have high HbA1c values, high fasting glucose, then they are very likely to have the state of continuous chronic inflammation. And so if you optimize glucose in the short term, you will optimize it also in the long term. And with that, you can lower inflammation both in the short and long term. And that's a great part. And so that's the thing.
I see. So, and also since you talk about so many different diseases, by studying just these few surrogate parameters related to glucose, your machine learning system basically looks at the time series in a way, right? Looks at the trend of the glucose to see what could be going wrong. Okay, so that's the biomarker side. And you also talk about, from the therapy side, you introduce certain foods, right? Certain behaviors to treat that condition once you diagnose it. How do you select? So do you select how does that work? Do you select like standard foods that are for like prescribed to everybody who has this kind of how does that become personalized to that person?
Yeah, thank you for your question. So I give you an example. When we founded the company, I was 93 kilogram. I'm 1 meter 83, so I was slightly overweight, and my fasting glucose was 104 milligram per deciliter. I was exercising 3 times a week, running 10K, mountain biking 50K. I was trying to eat healthy. Yeah, I was trying to eat healthy, but still, you could say that I'm on the verge to pre-diabetes. When I graduated 7 years before from university, I was 82 kilo. Obviously, I don't know my fasting glucose, but I assume it was less, right? But my life was pretty much similar, right? I didn't change that much besides that I was obviously sitting at the desk, but in university you're also studying, right? So you're still sitting at a desk. It doesn't really change that much.
Yeah.
So I gained 1.5 kilos per year after university. And as a good German, I used to eat muesli, which is oatmeal.
Yeah.
It's considered very healthy here, and actually that's why I ate it, because it's convenient and healthy at the same time, and it's really common in Germany. And I ate that every morning for my breakfast. And it turns out when I eat oatmeal, and I'm talking about like protein sports kind of oatmeal, so it's not like high sugar, it's or artificially flavored or whatever. It was a great product by a premium brand in Germany. It gives me a blood glucose spike to 190 milligram per deciliter.
Wow.
Yeah, that is almost diabetic, right? You can usually, when people have glucose rises above 200 milligram per deciliter, you start asking whether they might have type 2 diabetes. And so clearly, this is a really bad dish for me. Now, oddly enough, when I eat white bread with Nutella, my glucose spikes to moderate 140 milligram per deciliter. It does not mean...
Interesting.
Yeah, it does not...
So white bread and Nutella spikes it to 140. Yeah, but
chocolate cream.
Yeah, but whole oatmeal, which is so fibrous, which has, considered to be a really healthy whole food, spikes it up to 190 without any sugar added.
Yes, that's right.
Okay.
So that's super odd, and you would never expect that, right? And this Nutella, I mean, we're sorry for naming the brand here in public, but that's what I eat. So chocolate cream, white bread with chocolate cream, it gives me that moderate spike. Now, it doesn't mean that I should have white bread with this chocolate bread spread every day, right? Clearly, I should have a diversified diet, and I should not eat that every day. But what it does mean is that I should never have oatmeal, because this clearly is really bad for me. And ever since I haven't eaten that, and I lost 6 kilograms, and my fasting glucose is now at 93 milligram per deciliter. So clearly, I reversed my trajectory towards type 2 diabetes or pre-diabetes. And that is a great outcome. Now, how can you do that? Well, the issue is, first, you need to know what is important for the individual in the individual's diet. It doesn't help when I tell you, Aman, schnitzel with French fries is good for you if you don't eat schnitzel. Then it's completely irrelevant. It doesn't help when you are telling me, hey, Dominik, you should have, I don't know, vegan curries, when I don't eat vegan curries, right? But then also it has to be practical. And what we do is we have a standardized set of test meals where we are figuring out what is typically consumed food in your region. What do you usually have? In Germany, for instance, people eat a lot of bread, and they can pick either between white bread and whole grain bread. And with that, we try to derive standardized recommendations. In my specific case, I'm more of the white bread kind of guy. And when I'm at the train station, when I'm at the airport and I need to grab a sandwich, I just take the white bread. In other cases, perhaps people are the whole grain bread type, and they might grab the whole grain bread, right? So we have that for many different standardized meals, and you can pick those that you want to test. And this is one part, to give you general rules. Also, if you think about it, I eat a lot of bread. I eat bread basically every day, sometimes twice a day. So out of the maybe 35 snacks and meals that I consume per week, probably 20 are already including bread. If I take the wrong one, I'm taking 40% of, or 35%, 40% false food decisions per week. So that is awful, right? Because it's already a large share of my diet that's affected by that poor decision. And so this is why it's benefits to have these standardized rules. And then we also give you the option to test fully individual foods and drinks and whatever you like. Now,
Mhm.
I drink a lot of water and coffee, but once in a while, I want to grab a sugary drink. It's just, I feel like
Mhm.
it, I feel like treating myself.
Yep.
And in Germany, people drink a lot apple juice with sparkling water mixed.
Okay.
It's a common
Yeah.
drink here, right? And when I was a
Mhm.
little kid, I learned that that is actually not a bad choice because the apple juice, it's like juice, right? It's vitamins, it's fruit essentially. And that's what I learned when I was a kid in the 90s. Um, and and the sparkling water, it's called mineral water in Germany, right? Great name for
Yep.
water, mineral. I mean, it has minerals. How could a drink like that is fruit, vitamins, and minerals be unhealthy? But it turns out that this sparkling water with apple juice gives me a blood glucose spike that is just as high as a regular Coke. Now, I
Wow.
like Coke. I really like drinking Coke. And so when I want to treat myself, I'm taking the decision that I'm drinking something unhealthy in this very moment. But in this moment, I'm picking something which I like best, regardless of the glycemic response, right? But the apple juice with water is something. Just as a muesli, by the way, the oatmeal, which I consider a false friend, right? Because this is food that gives you the impression that is healthy, but it's actually not
Mhm.
healthy for you. So that is actually the worst part. The foods that we know of that are unhealthy and we think they are unhealthy, like a regular Coke, that don't hurt
Mhm.
because that food we are trying to avoid
Yeah.
generally either way, right? But the food that gives you the false impression of being healthy, that is an issue for
Mm.
you. And we are trying to figure out with you together which of those foods are. And for that, we have developed great IP using artificial intelligence.
I see. And so that's the diet part. You also said you asked them to change their other behaviors, like you prescribe them exercise or something like that. What are those? What are those things that you prescribe?
Yeah, so it turns out when you eat something and you go for a walk afterwards, it impacts also your glycemic response.
Mm.
So there are many people when they have a dish and they go for a walk afterwards, they will have a lower glycemic response. So they're lowering their glucose levels, which is healthy. But there are also people that have actually higher glucose levels. So we help you find out whether you should take a walk after eating or whether you should avoid it. And the same is for stress management. And when you wear glucose sensors, it's actually also a great biofeedback that you're getting. So
Mm.
when we analyze your glycemic response to food and taking a walk afterwards, we can tell you, hey, Aman, look, when you did this test phase with a glucose sensor, look, that was a great effect for you because it lowered your glycemic response by 25%. Today is a great day. Try to go for a walk after dinner because it will be better for your glucose metabolism. And if you tell that people, first, they learned that from the sensor and the biofeedback, and it
Mm-hmm.
really sticks to their brain. They really have memorized that because it was so plastic,
Yeah.
yeah, so they could grasp it really. And and so when we later on guide people, so in our product we have a phase with a glucose sensor, but that phase is followed by digital coaching and guidance. But we remind people of what happened when they wore the glucose sensor, how they discovered their personalized diet, how they discovered what behavior actually keeps blood glucose levels stable. And we use that always as a common theme to have them continue on their route and remind them of the benefits. This is how we're doing it.
I see. So so if I understand correctly, you basically use AI to detect these changes, right, based on the thing that the person is already doing in their life, right, and that that makes it easy for you to find interventions, and you probably have some system of the person tracking or noting down what they're doing so that your system gets more feedback. So how does what's happening under the hood in a general from a general perspective? What does this How does the system work?
Yeah,
And let's talk about inputs and outputs, and then how it does things.
yeah, great. So the inputs is easy. It's glucose and from a CGM system. So there are continuous glucose monitors.
Mm-hmm.
You can buy them online from Abbott, from Dexcom. There are other companies offering it, and it's it's growing actually, the space.
Yeah.
So this is one important input factor. But then also we have people track their diet, as I described it, and also activity, sleep, stress, stress management when you meditate or do breathing exercises, perhaps also medication and symptoms of disease. So those are all input factors. And then we derive personalized food and activity recommendations based on that. Now, the issue is that when I say glucose curve, people have this perfect curve in mind. It's not, because if you eat a mixed meal of different kinds of carbohydrates combined with proteins and fat, and then you go also for a walk, perhaps 20 minutes after the meal, that is all something that influences how the meal is metabolized. And you don't have that perfect curve. It has different spikes, it has double spikes, and so you have to describe that curve mathematically well, accurately. And then also you want to have food recommendations that are stable. Because if I recommend to you that you shouldn't eat muesli, to stick with the example, you want it to be reliable every single day. Now, when you only sleep 4 hours, you will wake up with a higher fasting glucose. If you have done sports yesterday and have run 10K or whatever, it'll also actually influence your glycemic response today. So what you do a couple of days before and how you sleep will influence your glucose responses of today. Now you have to correct for that. That is repeatable, right? That we are always getting the same recommendations. And I personally have done our product probably 20 times. And I have, on the meals that are important to me, I've always received the same recommendations when I've been doing the same stuff. So that's a great outcome. And that is what we put a lot of effort in. And we have trained algorithms to give you a great, reliable description of the glucose curves. And so this is the core technology, the core IP. We filed those for patent, and there's a lot of knowledge and data in it. So even we filed actually only part of that as a patent, but obviously a lot of data and a lot of mathematics have flown into that technology. And by the way, if the recommendations are accurate, then people will also have an effective treatment, right? Because it's like bullshit in, bullshit out, obviously. And in case of healthcare, it means not only bullshit out, it means also disease gets worse. So you don't want to have that.
I see. So if I understand correctly, the way the system works is the model basically looks at the spikes, but and in terms of the output, you said that the main challenge was in correcting for the things that the different things, the sheer variety of things you're doing to your body, right? You're working out 2 days before, you did a HIIT workout, and then that kicks up your metabolism for a couple of days, and you're getting different levels of sleep. That's the main source of IP for you, like how you correct for that and stuff.
Yes, exactly.
And these are machine learning models. So how did you train, or what's the story? How did this evolve? Like, how did this begin to get to a stage that's clinical grade?
Yeah, that's a great question. So when we started it, actually our goal was to predict your glycemic responses. And because we thought it's easier. But then after a couple of months, we figured, wow, it doesn't actually make sense to predict glycemic responses. And also because people like the CGM system, because it gives them biofeedback and it's so like tangible. So we kind of left that route of trying to predict glycemic responses. But what we also learned is that we didn't have stable, reliable results. We had some users purchasing our products multiple times and then asking us questions, hey, why did you recommend last time's white bread when I now should eat whole grain bread? So we realized that that is a problem. And there are papers out there that actually give you different ways to calculate the glycemic response. Usually, and it gets a little bit technical perhaps, usually you hear people talking about spikes, but that's actually not the right way to do it from an academic perspective. You can you need to calculate the area under the curve, right? So it's the integral under the curve that you're looking at. And now you have different approaches. Some people just take the integral above a certain baseline. Some add a baseline that is under an area that is underneath a certain baseline. Some subtract it from the other one. Some take it only within a certain range, right? So there are a bunch of different approaches. And we realized that all of these approaches, because at that time we actually already had quite a bit of data of glycemic responses, and we realized that in above 25 to 30% of the cases, when you use one of these traditional methods, you will have a false result. So, and the false result was benchmarked against the evaluation of a diabetologist. So you have basically the computer will determine whether a glucose response is positive or negative, so to speak, to make it a little bit, to simplify it. And then the diabetologist will also check that and say, hey, well, look, even though the computer claimed that this is a good response, it's actually not, because I can see these other confounding factors and so forth. And in the greater context of the entire day or the entire week, you can tell by, if you put it on a graph, that it's actually not a beneficial response, right? So we figured, okay, we need to, and this is actually more, the finding was, you can say it was a little bit of an accident, because we now were facing that problems, and we were wondering, okay, how are we going to deal with that? And then we're like, okay, well, because we have diabetologists in our team that have seen glucose curves from zillions of patients with diabetes before in their lives, sorry, I hear some noise in the back.
Oh, you want to take a quick pause?
No, okay, sorry, I paused. So
actually, it's a huge coincidence. I have something going on in the background that I need to go and shoo people away. I'll just take 1 minute, a 1 minute break. All right, I'll just be right back.
Of course. It's just I was worried about the recording. So I get back a little bit because I don't know if you need to cut it. So when we were looking at these glucose curves and saw that many of them were flawed. And since we had many diabetologists on our team, we wanted to give accurate results, and it actually was embarrassing, but customers were contacting us and claiming, hey, look, you're contradicting yourselves in your analysis. We then developed actually a quality measure where we calculated the glycemic response, and then we had a diabetologist double check them, right? So this diabetologist was then scoring the glucose curve and adjusting the analysis that the computer gave us. Now, that was great because accidentally, obviously, we also developed a lot of training data, because we now had these original glucose responses, and then we had the ones that were reviewed by the diabetologist. And with that corrected glycemic interpretations, we then use that for training our algorithms and as a foundation of the artificial intelligence model with which we then started interpreting glucose curves. And we trained that model. And we were able to reduce the errors to around 4%. So from around 35%, roughly 30%, we were able to reduce them to 4%. And we still are running this quality management process where actually certain glucose curves are screened and checked by diabetologists and trained staff right now, just to make sure that we get a really accurate result, which is also beneficial because the algorithms can get better. And so the system keeps on learning and improving, and we hope that someday we'll be at 99.9% accuracy, perhaps, of the analysis. That's the story.
Wow. So the traditional non-machine learning way of doing the analysis on your glucose levels was to just look at the area under the curve, right, in different time blocks, and use that with some standard thresholds to make a prediction of what's going on, in a sense.
So
of course, it's slightly more sophisticated than that, but
yeah, you could say that.
Kind of.
So the AI model was that we were looking at the area under the curve of a glycemic response to a meal. Mm-hmm. We then were scoring this. We were evaluating this glycemic response, whether it's good or bad. We then had that double check with a diabetologist, and this actually generated the training data.
So, but the first model, the way it was labeling that area as good or bad, was based on some standard threshold, or like what
exactly.
What was the
standard thresholds? Yes, you're right. Standard thresholds. Yes.
And so you said that methodology, just having those standard thresholds, was has an accuracy rate of only or of only like 7. Is that the accuracy rate 70%, or is it the opposite?
In 30%, the diabetologist would correct the result that the traditional model yielded. Yeah.
Okay, so it's 70% of human accuracy, and maybe even slightly lower of in terms of the actual accuracy that needs to be, because the dietitian itself could be
could
biased
also,
or whatnot.
Exactly. Right? Yeah, you're right. Yeah.
And just a quick curious question here: how long has this field of using glycemic response to, like, when you found those algorithms that you basically I don't know if you did your own research or you took that from the literature, how long has this field been in place?
Well, the entire field of looking at glycemic curves,
that problem, that the research on using that to predict automatically.
You mean how long we took to build these algorithms?
No, basically, how many years have people been using that kind of algorithm? That kind of thresholding.
Well, I mean, the good, that's a good question. So the good answer is actually that usually people are not using glycemic responses to food to treat diseases. So if you will, no patient so far has been treated in a wrong way, I guess. But the research that has been done around it, that's probably 15 years. I think since the mid-2000s, people have been researching about glycemic responses. And I mean, we are, you can ask that actually, how accurate are our diagnostics? And it's an interesting part, actually, because since we are generating all that data, it's a natural thing for us to also look at diagnostics. Can we diagnose a disease perhaps more accurate than current procedures are doing it, or even can we diagnose responders to our therapeutics and then adapt accordingly? And in diabetes, it's so people use a standard measure that is usually the HbA1c. So it's basically how much glucose gets bound to certain blood molecules, and that gets bound there over a longer period. So you always look at a 90-day window, and that is a diagnosis characteristic. Now, because of the arrival of CGM systems, people are starting to look also at other measures. But what we have found actually is in patients that don't have diabetes, for our other digital therapeutics, they are showing also glycemic, well, how should I say that? They are also showing glycemic profiles that are not healthy, but not diabetic. So this has not been described in the literature before, and I find it super interesting because you have patients with a certain skin disease, and you see that their fasting glucose is a little bit higher than that of healthy individuals. Thinking, wow, they probably have a form of chronic inflammation, and this is why they have the skin disease. But if they went to their physician, no one would give them the recommendation, try to manage your glucose levels. So actually, there's no treatment for these guys. They would just get topic treatment to apply to their skin, perhaps, to fight the inflammation. But they would not get a treatment that really targets the root of the disease. And we are observing these kind of people in our data. So that gives a whole range of new applications for the technology to all different kinds of treatments. And also, if you see that, you can rework that. Because if I see a person that has a skin disease and an unusual elevated glycemic profile, like higher fasting glucose, higher meal spikes, typically, then I can infer that I'm likely going to be able to offer an effective treatment when I manage that condition, right? So it's like back solving. You're looking at the glycemic profile in people with a certain disease, and then you can derive from that yes, probably your treatment is going to be effective. And it's a good approach, actually, because usually when you develop a new therapy, you don't know if it's going to work in these people, right? The discovery process is different. You just start with an idea. I want to develop a treatment for smoking cessation or whatever, because I realize that the market is big enough. I realize that that is a problem. And so I'm just embarking on their journey to develop that specific treatment. But that is not how we are doing it. We are looking at the data, see, well, how is the glycemic profile? Well, it's odd. Okay, then we are embarking on the journey. So we're embarking on the journey a little bit with a head start, because we already know that we have a benefit here, and we are more likely to address the treatment, right? So yeah.
I see. So in summary, I would say there are some benchmarks based on the research that you could beat in terms of, okay, how accurately can you predict that the thresholds are wrong or right or whatnot.
Yeah.
However, in terms of the field of actually using that for clinical purposes, that's a complete green field in your opinion. You're saying that there hasn't been much activity, and you're kind of and there definitely, I think most people haven't heard of any company or any doctor ever asking you to provide your glycemic report for a skin disease.
Yeah.
So to build on that, to segue into what does it take to make it clinical grade? Like what kind of, from a regulatory landscape, what level of clearance or what kind of level of regulations apply to your technology? And do you offer a nutrition-based therapy, right? Which kind of, does that change the equation a little bit in terms of how strict the regulations are for you? Give us an overview of what that looks like.
So in general, I mean, nutrition is at the core. It's not the only part of the therapy, right? But it's at the core. And obviously, nutrition is low risk, because even though if I gave you a recommendation that is not completely correct, it takes a little bit of time until you develop a condition that gets worse, right? It depends obviously a little bit on the disease. If you are in oncology, for instance, perhaps you want to be super correct. If you're in neurodegenerative diseases, you also want to make sure that it's super correct. If you're doing something in the pre-diabetes space, then it still needs to be correct, but you have a higher margin of error, so to speak. And in general, so these digital therapeutics, they are regulated as low-risk products. And in Europe, which is the country where we are in, or the region where we are in, we are a class 1 medical device under the medical device regulation.
What does that mean again?
We are a class 1, so that's a level of risk. So if you want to develop medical devices, so software is essentially, it's a medical device, even though it's software, but it's called software as a medical device. And the regulation, and that is not only in the EU, but also in the US, it looks at the level of risk. So presumably you have an artificial knee, right? Then you have to get surgery, and if it doesn't work well, you fall off stairs or whatever, right? And you can really severely hurt yourself, and it's invasive. So if it's not clean, you can get an infection.
A lot of risk.
So so a lot of risk. So so it has a higher level of risk than when we tell you our software calculated for you that you shouldn't eat oatmeal, right? Because
that would be class 3, class 4. That would be higher class.
Yeah, and ours is the lowest class, and the lowest class is class 1, and in the US that would be also the case. Even in the US, they are these days they don't enforce FDA clearance if the products are super low risk. So that's even better. But it's a little bit comparable to the EU. And this is what we are doing. Now, in general, if you use artificial intelligence, then you are subject to a higher risk class because artificial intelligence is a black box. So what we do is we develop we train the algorithm, then we freeze the algorithm, right? We take it out. So it's not continuously learning, but it's a frozen system, and that we apply to the medical device. So the algorithm has been trained using artificial intelligence, but it's not active artificial intelligence, if you will. And this is why we are able to keep that lower medical device grade, because obviously we have a system of checks and balances, whether the algorithm works well and so forth, right? But then obviously we are continuously improving the algorithm using AI. It gets an update, it gets checked with a system of checks and balances, it gets checked for security, and then we can put it into the medical device again, right? And so what's important in this medical device regulation is that you're managing risk and really have a good system in place, quality management, also software, security systems, data protection. We are about to be ISO 27001 certified, so it's a large project where the entire company is affected. But I mean, it's about health and people's lives, so it's really important that is really working at a high quality. And the EU is now working on an additional AI regulation. Personally, I mean, my personal opinion is that it's not a good moment to regulate it because we are very early in the development, and I don't know whether the EU is doing itself a favor with that. For us, I mean, as a medical device company, we have so much paperwork to do. So
already,
yeah. So this little bit of an add-on will not harm us really anymore. But I can see that there are other companies that will really cry when they see that new regulation.
I see. So far the regulations haven't been talking. So the fact that you use AI increases the risk. Is that written in the regulation, or is that inferenced by some other factor that just gets affected because you use AI?
Sorry, could you repeat that, please?
So I mean, so because you use AI, does that directly, increase the risk level based on the regulation, that like the regulations are written that way, that if you use machine learning or
Yeah.
something like that? Or is it that using AI changes something that else that's that is then reflected in the regulations?
Yeah, so if you were using AI constantly, that keeps on learning as an active tool within the software, then it would increase your risk class, and you would have a
Mhm.
higher regulatory burden. Um, and yeah,
Wow.
so
These seem like really new regulations, because
yeah,
only like deep learning has only been around in actively for like 4 years now, right? 2016, people started talking about deep learning, like, oh, AI, machine learning, and everything. But it usually takes time for regulations to catch up, and it's interesting that you already have these things in Europe.
yeah, it's interesting actually. I mean, it's the MDR was, I mean, the medical device regulation was renewed because they had a scandal in France
Mm,
with breast implants actually. So
okay.
there was a company that was selling flawed breast implants that made people really sick, and this is why the EU then started to rework the regulation. But
I
and
see.
I guess because this was done throughout the past 5 years, they launched it last year in May. Oh no, they launched it this year in May. Originally, they wanted
Mm,
to launch it in 2020, but they postponed this due to COVID. And I think because it was just in this time frame of the last 5 years, that is why probably they changed it. So it was, for the
I
regulator, you
see.
could say that it was a good moment, but yeah, for everyone else, I guess, yeah. I mean, look, the issue with regulation is we are adhering to regulations. And
Yeah.
it's something that I think a company like ours needs to do. We are in a healthcare, and it's something we just live with, where we are diligent, and I mean, 10% of our staff in our company is working on regulatory. If you look at our annual accounts, you will start crying when you see what we spend on regulatory advisory. But
But how much? How much? Now you gotta tell us.
yeah, well, it's in the upper six-digit figures, right? But I'm talking about one
Damn.
year. Yeah. So
In 1 year alone.
yeah,
Nice.
and we're talking about a company that has 40 people and is a startup, right? So
Damn.
if you raise a Series A round, you can set aside maybe between 10 and 20% for regulatory
Paperwork.
advisory. Yes, paperwork. Um, so and but the thing is that I personally don't think that they're going to prevent any scandal from happening with that. Um,
Yeah.
because they don't have a system of checks and balances in place. They are, if you want to prevent a scandal, then you really have to dig deep constantly and try to figure out if there is something going wrong. And the enforcer of the regulation usually doesn't have the resources for that. I mean, we had Wirecard in Germany, right? We have financial
Hmm.
regulations. Wirecard was a financial services company that went bankrupt, and they cheated in the billions, and they went bankrupt last year. So we had that,
Wow.
and we have all financial regulations in place, right? It's not a matter of uh, it's not a matter of lacking regulations. It's a matter of lacking enforcing and understanding where people are not obeying to these regulations, and that is
Yeah.
about that is, in my opinion, the bottleneck. So I'm a little bit annoyed by that because as a citizen of the European Union, I'd be incredibly happy to have good regulations that are enforced well and that
Mm.
work, that products are safer but at the same time
Yeah.
at very high quality and competitive prices. That is what I want, because I'm not only developer of medical devices, I'm also consumer of medical devices. I'm also a
Mm.
patient. I'm not only the developer of treatments, I'm the patient that receives treatments, and I want them as good as in quality as possible and as safe as possible. And I don't think that the EU is solving for that in the best way. But I mean, I'm an entrepreneur
Oh,
and not
we
a
do what we got to
regulator.
do, right?
Maybe in some other
Yeah.
life. So why should I complain? It's I cannot complain about things that I'm not actively working on. So
Yeah. Cool. Yeah, that totally makes sense. Upper six digits is a significant hit for a startup, and I presume that number doesn't care whether you are at the pre-seed stage, whether you're at the seed stage, whether you're at the Series B stage, right?
yeah,
If you're putting a product out in the market, you have to go through that paperwork anyway, right?
yes,
It doesn't matter if you're a small company or a big company,
yeah,
which affects the fundraising strategy that you have, right?
yeah,
For sure.
yeah,
So
for sure.
now let's talk about again, the financial side, right? Since you're already talking about it, what is the go-to market? Who are your customers, and how do you reach them?
Yeah. So essentially, we are selling to health insurance groups. So they are the people that pay for it.
Mm.
At least that's going to be in Germany the case. In other markets, we will be also selling to employers. It depends a little bit,
Hmm.
right? So
Okay.
that's an issue in healthcare because many markets are regulated in different ways, right? And with
Mm.
drugs, it's easy because in drugs you have clearly defined regulatory pathways to receive reimbursement of your products, and those are um, reasonably similar across the entire globe, right? There are differences,
Yeah.
but I'm simplifying.
Mm.
In digital therapeutics, that's different because in many jurisdictions, you don't have that clearly defined regulatory pathway. In many jurisdictions, insurance companies are not covering them, and others, insurance companies are covering them. So you really have to go region by region and try to understand each market independently, and then you can develop your commercial strategy for that. And what we are doing in Europe or in Germany is we are targeting the reimbursement of health insurance companies, and then physicians have to prescribe it. Now, obviously, many physicians don't know about digital therapeutics at this moment, so you can also market to patients, addressing them, telling them, hey, look, this is good for you. Go tell your physician that she should prescribe that digital therapy to you. And
Yeah.
so you have to market to basically three sides: insurance companies, physicians, and patients. And
Hmm.
and that is in healthcare. It's a complex marketing strategy, but it's fun actually because it's
Wow.
harder problems are more fun to solve, right?
How do you go about that? Just a little bit more context, because that's like, yeah, I mean, it's already hard enough to sell to one group.
Yeah,
So what are
I
you
mean,
doing?
what I try to understand usually is where the pain points are for each group, right? So for the
Yeah.
patient, it's fairly easy. The patient wants to get
Yeah.
rid of the disease and of the symptoms.
Hmm.
For the insurance company, well, they want to lower their cost, right? And but then again, insurance companies have the mandate, at least in Germany, because those are governmental entities, they have the mandate
Mm.
to pay for a certain level of treatment, right? So you have to make sure that you understand that they have certain cost pressures, and at the same time
Mhm.
also work with them to reimburse the products. Um, and then you have the physicians, and
Yeah.
there are multiple aspects. That's really difficult because physicians, um, first, they don't have much time, right? They want
Yeah.
something where they save time, perhaps, and that they don't have much work with. Then obviously they
Mhm.
also need to make money. I mean, they have to feed their kids and pay their bills, and it's understandable
Yeah.
that they want something that that pays them reasonably at a given level of time they're expending towards it. But then also they want to provide their patients with a great solution, right? Because
Yeah.
a physician is an advocate of a certain treatment. And so she wants to tell her patients, look, if you take this, then it's going to work, because the patient is not supposed to get mad. You prescribe me a treatment that I spend a lot of time with, or that gives me side effects. That doesn't work. And so you have to address these certain factors, and you do that essentially with content marketing, if you will. Right, marketing to healthcare providers is essentially content marketing, because you
I
use your
see.
clinical trials, the data from your clinical trials, to develop, to craft research publications and press releases, and present that in conferences, and explain to them, look, if you prescribe this treatment to your patients, they're going to benefit because it's going to be an effective treatment. They don't have side effects or limited side effects, whatever you're creating. And in the case of digital therapeutics, you can
Yeah.
say that they don't have side effects. So that's a huge benefit, right? Because most drugs do have some, and it's safe, and
Yeah.
your data is protected, and so forth. And this is how the product works. So you have to give them comfort, and it takes time. But the great part is, if you have a physician as a prescriber, it's kind of like you're having a subscription, right? Because she's going to prescribe on a continuous basis, right? So, I mean, she's going to see patients every day. And if you convert one person and turn them into a prescriber, then this is going to be an account for you that generates sustainable, continuous revenue. So that's an interesting way, perhaps, to think about it. Yeah.
Wow, that is so incredible and so helpful. Thank you so much, Dominik, for sharing that comprehensive overview. Uh, yeah, it's interesting that on the doctor side, it's the most complex, right? Naturally, because for the insurance space, it's pretty much a straight sale. Like, hey, do you cover this or not? Like, here's
Yeah.
the data, here's the proof that it works. If you cover this, it's gonna reduce your premiums. There you go.
Yeah.
Right? It's cheap. It's better than drugs. You can just go for it. Um, but and on the patient side, it's easy as well if you just target the right market in the right geography. But on the doctor side, getting a doctor to prescribe a new system is not just about how effective it is, but also about how much they get paid for
Yeah.
prescribing it to their patients, right?
Yeah.
Which is a sad state of affairs. But I mean, whatever. Like I'm not going to comment on.
No, I mean, I think
Um,
it's totally fine. I mean, each has its pitfalls, but it's just you have to
yeah,
solve for it. I mean, on the insurance side, it's fairly easy, but it takes a little bit of time, because, right,
yeah,
as I said,
yeah.
these
It's
are
a B2B
governmental.
sale.
It's a
Yeah.
it's a big company, right, with long sales cycles. But I mean,
Mhm.
to be honest, people are oftentimes complaining about the speed at which innovation gets adopted, specifically in the startup ecosystem. I think we cannot expect from people to change that quickly. We just have to accept that everyone has its own speed, and we have to adapt our business to that. And I think that's totally fine, right? So
Mhm.
in our case, I'm super happy because we have great investors, and they understand how healthcare works. And after all, if you
Mm.
understand that healthcare is a great market, I mean, if you look at the
Oh yeah.
returns of pharmaceutical companies, I guess it's out of question that you can find a solid business approach to that, and it can be a, a strong business. But it has its own rules, and you have to accept that, and you have to play by them.
Mm. And speaking of that, compared to pharma, their way of doing research and doing development is basically to brute force the entire thing, right? They
Yeah,
screen millions of substances to find millions of compounds, and then they brute force, try to find anything that sticks, anything that
yeah,
works, right?
yeah,
Although that has changed, you have some people who try to actually build molecules piece by piece for a specific marker, but either way they're super expensive, right? But if you just scrap all that whole in vitro testing and everything, you focus on an AI digital therapy solution which uses nutrition, right, and still gets paid by the insurance. I guess the innovation cycles are much faster, right?
Yeah.
The iteration cycles for a product development. So that kind of definitely also affects the amount of money you need to raise at different stages, right?
Yeah.
From investors, right? How's your fundraising story and your fundraising strategy being different from, let's say, a typical guy who goes and says, "Oh, I need 25 million to get started," like, with my new pharma company.
Um, yeah, I mean, you have among VCs, at least in Europe, in the US, it's slightly different landscape. Which
Yeah.
by the way, I think the landscape in the US is much better than in Europe in that respect. You have either life science VCs or consumer tech VCs.
In Europe,
Right?
you mean?
In Europe, yes.
Okay.
So the consumer tech VCs are looking at medical devices and healthcare, and they are like, "Whoa, we don't understand it. It's medicine. We're business guys. It's regulated.
Yeah.
We shy away from that." And plus, we like to copy stuff that has been done in the US, anyways. Right? This is a German approach, just plain copying stuff.
Well, so for those not familiar, he's talking about one particular company, I think, that is
Yeah, but
really famous for, right?
it's an
That is really famous
ecosystem
for
that has
copying. Yeah,
emerged. It's an
yeah, kind of like
ecosystem
pollutes the whole
meanwhile.
ecosystem,
Yeah.
right?
So
Their name has something to do with spaceship. Just a
yes.
quick reference there, but we won't name them anyway. Yeah,
Yeah.
but yeah, go on.
So
Sorry.
yeah, so this is our take on innovation over here. but either way, we are this is what we this is one part of the VC ecosystem, and then the other
Yeah.
ones is life science VCs. And the life science VCs traditionally were okay, molecule, patent, clinical trials. That's it, what we are funding, right? So the digital therapeutics is kind of in between. Because for one, you have a technology product, you can iterate faster on that.
Yeah.
It doesn't have patent protection usually. In our case, it's pretty special that we are actually filing something for patent protection. But in general, there are very limited options for patent protections. And but I think the system is changing a lot because people realize that that it's a really urgent need. And as I said before, 80% of diseases are related to lifestyle. In the US, expenditure on treating such diseases is around 3.4 trillion, 3.4 trillion euros or dollars in the US alone, spent on treating these kind of diseases. So it's a huge market, and pharma companies, which are actually innovative, right?
Yeah.
I mean, it's a very innovative R&D driven industry. They are also looking at it because they are. I mean, R&D of drug development is getting more expensive, and in digital therapeutics, I believe that you're getting much more bang for every R&D buck that you're expending.
Yep.
And that, I think, is a great business opportunity for pharma, for tech, and for VCs, in my opinion. And I see much more VCs getting into that space. I mean, for us, honestly, the way it has changed within the past 4 years in our ability to fundraise and to get into discussions with VCs, it's incredible. It's a completely different story. You can really tell that the market is expanding, and I think it's such a great environment to be in because everybody is
VCs
moving.
And that's VCs. That's not even institutional investors. Like, let's say Pfizer wants to invest in tech startups, or something like that.
Yeah, I mean, but even for institutional investors, we are even seeing institutional investors asking, "Hey, when are you going to IPO, or when, or also setting up specific investment trusts vehicles focused on digital therapeutics and digital health. And I think that's great because everybody is moving. Regulators is moving. Germany went ahead with a new Digital Healthcare Act that they enacted at the beginning of 2020. But now France, the Netherlands, Belgium, many countries are following. The US has many great examples of strong digital therapeutics players already,
Yep.
and they're even growing. The technology is getting better. I think wearables in general becoming cheaper, becoming more accurate, giving you the opportunity to identify more digital biomarkers. You can also develop synthetic digital biomarkers, so you have a combination of certain things measured by wearables, and then you can use that again as a proxy for predicting certain disease symptoms. So I think it's an incredibly interesting space, and much things are going to happen. And to be perfectly honest, for me, I'm always trying to think about it as a patient. I think, at least in Germany, what you're doing in Germany is that you visit your medical doctor, you get a diagnosis, then it's like, yeah, here you have the prescription, you go to the pharmacy, they write something on the pill pack, how often you should take that. You don't know how to behave, what else can you do. For instance, I have problems with my shoulder joint, right? I don't know, what exercises can I do? How often shall I do them, right? Am I sleeping right? Is it good for me to sit at the desk and be typing, whatever, right? So what can I do to help speed up the healing process? And this problem is not being solved at all in our society, and digital therapeutics solves that kind of problem. And also, if I have side effects from a pill, is it normal or not? If I have a little bit of, I don't know, stomach problems from a pill, should I annoy my physician immediately? I feel bad because the guy is time constrained, and I have the feeling every time I visit him that I shouldn't be here, and the office staff gives me the impression that I have to wait for weeks, right? So I think digital therapeutics are a great intermediary between patient and healthcare provider, but then also have a real therapeutic effect and enable patients to take steps for themselves. And honestly, some people are really cynic about it, specifically when we talk about some major chronic diseases. I have the strong opinion that every single person in the world wants to be healthy. We just have to find ways to enable them to achieve that. And this is what digital therapeutics and predominantly Perfood is working on. But I really
absolutely.
believe that.
I completely agree. I think the way, and me being in the seat of the host of the Age of AI podcast, I get to see a lot of companies across the horizon who are trying to do something different, right, in the space. What I've been seeing out of Europe alone, right? Look, forget about the US. Out of Europe alone, a lot of these companies spring up recently. For example, one of my previous guests is a company called Ordering, and they basically diagnose a lot of diseases from voice data. Just by hearing your voice and putting it through a machine learning model, they can diagnose like certain neurodegenerative diseases, certain other aspects about speech impairment and whatnot, COVID, some respiratory problems. And I'm seeing like this thing called come together. I think 10 years later, hopefully 10 years later, when somebody goes to the doctor for anything, right, before they have to give a blood test or whatever, or even if they do have to give a blood test, they will not get like, hey, here's your prescription, go to the pharmacy and get this list of medicine.
Yeah.
It will be a much different and much more holistic checkup, number one, right, where you'll have a lot more data, right, from your mental health to your all the different things, and you'll get a complete picture of what's going on in your body, right? You will get therapy that is much more holistic before you even get a prescription. Maybe they'll give you a lot of like stuff like, for example, what should you eat, what should you do, what should you not do, how much should you sleep, from and stuff that actually you can redeem from the insurance company, right? I think AI single-handedly as a blanket technology is kind of going to make people a lot healthier, just digital therapeutics alone, because it's not
Yeah.
just that it's a $3.4 trillion addition on top of what's going on. I think it's actually going to eat up
Yeah.
a lot of the pharma dollars that people spend,
Yeah,
right?
and you see, I mean, it's an amazing technology that you've been describing with the voice recognition. If you have a neurodegenerative disease, first of all, you can diagnose it very early on, and
Yeah.
then you can use a product like ours to have a very early conservative intervention and show
Mm-hmm.
the patient basically real time or daily or weekly, monthly development and progression of the disease, so these patients can actively work against further progression. And I think that's amazing because it's simple. It doesn't involve the blood test. It's you can do it at home. You can do it anywhere, right? You don't have to bother whether you have remote care or whether you have enough physicians in a certain area, in a rural area. I think it's so amazing, and I'm really looking forward to that. And I think our generation is incredibly lucky because we are equipped with the technology to take care of ourselves in an effective way, but that is also doable, right? And we're going to end up being healthier. And honestly, that's what I care about. I think I'm not going to live forever, and that's
Mm-hmm.
totally fine. But being able to be at my full mental capacity, to be as good as I can in my physical capacity, full consciousness, and
Yeah.
not sick. This is what I want to be. This is for me healthy agent, and this is what we are
Mm-hmm.
working towards at Perfood. Yeah, and together with these diagnostics companies, I think it's an amazing match actually.
Yeah, like imagine, I mean, I would love to be able to be a much, like, let's say life expectancy for us is 100 years, and that's reasonable. Like in Japan it's already beyond 100 years. I think for us it's also probably 100 years, right?
Yeah,
At this stage, imagine being an 80, 90-year old who is much healthier than any 80 or 90-year old has been in history,
yes,
right?
yeah,
Like almost like you're like in your 50s, but you're 80 or 90 years old. Like imagine just that kind of quality of life, and how much of a transformation it's going to make to the whole economy, right?
yeah,
If people are productive, like I think the retirement age is going to just keep getting pushed and pushed and pushed. And like I think, like, from my seat as a host of this podcast, it's like I'm more optimistic than ever before about the future of our species.
yeah,
Even though I know that a lot of climate change is there, and things are happening, but overall it just makes me super excited to see what's in
yeah,
store.
yeah. I totally agree. Same here.
Yeah. Well, thank you so much, Dominique, for being such an amazing guest today for us, and for educating us about so many cool things today.
Thank you, Arman, for being even more amazing host, and it was a great pleasure. And yeah, I hope to be able to connect anytime. So if you're ever in Germany, reach out. I show you around.
Awesome, man.